joining me today discussing new treatment pathways for knee osteoarthritis, non-surgical treatment options. My name is Seth Sherman. I'm an associate professor at Stanford and fellowship director of sports medicine. I'm also head team physician for Stanford Cardinal football. My major passions are knee joint preservation, and so I see many patients who may benefit from both non-surgical and surgical interventions for focal cartilage diseases or early to moderate osteoarthritis, which will be the focus of this presentation. These are my faculty disclosures. Our learning objectives today are to compare and contrast the evidence related to non-surgical treatment options versus perhaps some of the suggestions from our major association guidelines. There are areas of concordance and areas of discord, and we will highlight these appropriately. We also want to examine the efficacy of hyaluronic acid in patients with osteoarthritis of the knee and see whether there is evidence in HA and whether it can delay the need for total joint replacement. And finally, I'd like to explore some other non-surgical treatment alternatives for knee osteoarthritis. By way of background, osteoarthritis is estimated to affect 250 million people worldwide, and that's just talking about the knee. So essentially, symptomatic osteoarthritis may affect 1 in every 8 adults in the United States alone. So there is a huge disease burden and a tremendous opportunity for us clinicians to make a difference in people's lives. You can see on this graph that the knee is the most common site in blue, followed by the hand and then the hip, as you see in green and red, and you can see the population breakdown between the genders represented graphically. Knee osteoarthritis accounts again for about 85% of this disease burden worldwide, and so that is the focus of my subspecialty and also many other physicians and associated healthcare providers across the globe trying to battle knee osteoarthritis, both non-surgically and surgically. It's important because OA consumes between 1 and 2.5% of the GDP of developed countries. And the majority of these direct costs are due to joint replacement surgery. And so alternative pathways or strategies to reduce the need for this final surgical procedure, or to put off that need to only those appropriate candidates who failed conservative treatment, is a worthwhile endeavor. Here we're going to deep dive a bit into some of the guidelines from the different associations, particularly our American Academy of Orthopedic Surgery, and looking at osteoarthritis of the knee. This is easily found online or in print version, so I encourage you to get it and to read it and to compare and contrast it with some of the other evidence that I'll be presenting. Before we go there, I want to take a 10,000-foot view and step back, and we must recognize that in order to effectively treat knee osteoarthritis or any osteoarthritis, we really have to treat the whole patient. It's not just about let's do an injection. As we'll see, many of these are not curative. They help modulate the environment and reduce inflammation, pain, improve function, but they don't work in a bubble. And so the major things that we can do in addition to potentially injection therapy can really help your patients a lot. And one of those recommendations that we can never forget about is weight loss. I know this is a challenging topic for many of us, but we have to get good at addressing weight with our patients and understanding whether they have nutritional needs that can be met through referral pathways, whether they can combine that with low impact or other exercise to sustain this over the long term. But load reduction is critical. And so early on, when they can't or haven't lost weight, using crutches or the like to reduce load can help. Unloading braces can also help, but weight reduction is really what's going to sustain them for the long term. Early on, activity modification and rehabilitation. So that's physical therapy and or home exercise programs. I mean, there's just great evidence to support those things for the treatment of osteoarthritis, and we must not forget them and just rely on a single or multiple injections alone to treat our patients. You can see some of the other things, and we'll go through them, these adjuncts, but the most important are really listed here. So here's some of the guidelines for pharmacologic treatment. You can see from the AAOS versus the ACR versus the OARSI. And, the guidelines vary. And so the strength of recommendations, those things that are inconclusive or have no recommendation, also vary amongst groups. I think you can see here that the majority recommend pharmacologic use of anti-inflammatory medication. There's mixed recommendations regarding the use of Tylenol. There's some recommendation for the use of tramadol. I think interestingly, and we'll talk about it, there's no or mixed recommendations for the use of hyaluronic acid. So the AOS cannot recommend it. The ACR has no recommendation, and ORC is uncertain. And so, I think there's great room for continuing to evaluate and reevaluate the evidence, to get on these committees and challenge the current recommendations and continue the evolution of our pathways for knee osteoarthritis. So what about steroid injections? These are extremely commonly used. I use them, and when I query my colleagues at major meetings, by a show of hands, the majority are using them at least in some capacity, either the short-acting corticosteroids or some of the newer, longer-acting versions. And you can see some representative papers here, looking at safety, looking at efficacy. We can see one of the papers out now looking at the newest formulation of a longer-acting triamcinolone that takes advantage of microsphere technology. And so what is the bottom line on corticosteroids? These should definitely be in your armamentarium. They can be helpful short-term. The short-acting steroids really go away within several weeks. The longer-acting steroids may stay for several months. And so again, these can help patients in specific situations get over a hump, but they're not staying in the joint long-term. And so if your patients have sustained improvements over 6 months to a year, it's likely that the other interventions and modalities are kind of taking over and taking the weight of improving symptoms. These are low risk. They're easily approved by insurers. So they're usually our first line interventions. They're inexpensive. They're easy to do at point of care, whereas many of the other things we'll talk about need approval or pre-approval, which is a very different process and requires patients to come back to the office. One thing that I'm passionate about and we've published on is looking at the toxicity of the different formulations of corticosteroids, and also looking at the toxicity of combinations of local anesthetics and corticosteroids. And so you can see this is our in vitro study. You can see here our in vivo study. But the take-home points are that not all cortisones are the same. We found, as have others, that Kenalog is seemingly the safest corticosteroid for articular cartilage and for synovium, as you can see in live dead staining, versus some of the other corticosteroids. And so that is the one we preferentially use. We've also found that, and other investigators have found this previously and confirmed this, that many of the local anesthetics are chondrotoxic and synoviocyte toxic. And so we must be aware of that. And I really don't use local anesthetics in the joint anymore. Particularly, I do not use 1% lidocaine in the joint. You may be able to use dilute amounts of bupivacaine or consider other longer-acting agents like ropivacaine. But I've found that I just use my corticosteroid with a saline vehicle, and that is safe, and it delivers it to the appropriate spot in the knee. And then I really don't have to mess with any kind of local anesthetic. I definitely sterilize the skin, and then I can use a cold ethyl chloride spray. And it really hasn't changed much of my practice, except likely not putting cells on edge and killing the chondrocytes that we're trying so hard to protect. Hyaluronic acid, you can see here the molecular formula, and we can see this is a naturally occurring substance within the knee joint. To try to understand its endogenous role, we can look at a knee to the left where it's totally normal, and then a knee to the right where it basically has gone through the cascade of degradation and breakdown, losing both mechanical properties and viscoelastic properties of the endogenous synovial fluid. And what essentially happens is that there's a shift from normal to abnormal, which includes more low molecular weight hyaluronic acid and less high molecular weight hyaluronic acid. And so viscosupplementation is a means to help bring back some of this HA that has several proposed effects and mechanisms of action. There's evidence that this may be chondroprotective, may help aid in proteoglycan and GAG synthesis. This may have some mechanical or lubricant properties, and actually can help, frankly, with analgesia. And so you can see the reference down below, which cites a lot of the evidence for these different arms and different properties of viscosupplementation. But we must be cautious. Not all hyaluronic acid is the same, and we must not think about them the same or treat them the same. We have to think about the source. Is this naturally derived avian? Is this chemically derived avian? Or is it derived through bacterial fermentation? We think about the form. Is it a hydrogel, a solution, a fluid? We think about whether it's cross-linked. We think about what the concentration is, as there's a significant variation in concentration with the different available products. We think about the dosage. Some products are meant for one, some are meant for repeat, 3 to 5 treatments. And then we must obviously look at subjective and objective outcomes, clinical efficacy, and again, even there, not all HA is the same. I refer you to this article by Roy Altman and AJSM, and the take-home points were to try to compare some of these different formulations. So looking at low molecular weight versus high molecular weight, and looking at avian versus biologic fermentation. And when all is said and done, and you can see the different charts and graphs here, they found that those products with a molecular weight of 3,000 kilodaltons consistently demonstrated more favorable results in both efficacy and safety than did those with lower molecular weight. So again, not all HAs are treated the same. If we look here, avian versus biologic fermentation, again, they found that the biologic fermentation demonstrated more beneficial safety profile than avian, significantly fewer injection site flare-ups or effusions. One of the main things that we do worry about is pseudo-sepsis, which sometimes can actually lead our patients not only to hospitalization, but also back to the operating room or to the operating room for the first time. And so I think conscious effort to reduce those flare-ups is very important. And so when it comes down to it, and there's some give and take here, these are just generalizations, and you must know your individual product and the safety and efficacy in your experience and in the literature. But in general, we try to go towards those with the higher molecular weights and those from biologic fermentation. And so that covered kind of safety and efficacy in general, but now we'd like to kind of pivot for a moment and look at perhaps some evidence about hyaluronic acid injections and whether or not these can actually be used to help delay the need for total joint replacement in patients with knee osteoarthritis. To look at this, this author group took evidence from a large US health claims database. So we obviously have to understand any limitations from these large databases, but they can get big numbers. And if you ask the right questions that are very much black or white. Total joint replacement, yes or no. HA injection, yes or no. You really can get some compelling information. And so here we can see what they found. We're looking at the mean time to total joint arthroplasty. And you can see in that group where they did not use any hyaluronic acid injections, that the mean time was well less than 1 year, just over half a year. Whereas if you have patients who've gone through a course of hyaluronic acid, that extends to 1.4 years. And if you've had patients who get response and can come back for treatment every several months, several times a year, actually can go free of joint replacement up to 3.6 years. So I think you can see here nicely and graphically that in this particular database study, that the HA injections were associated with a dose-dependent increase in time to total joint arthroplasty. So obviously this is food for thought as an option for our patients. And, I think it's a challenge that while we do have, reasonable evidence on safety and efficacy and delayed arthroplasty, that our major supporting academies do not have firm recommendations at present for HA, and insurance companies also are continuing to fight back and are not approving HA for a lot of our patients. The out-of-pocket costs are quite expensive. But I think the take home for me and for us is I still try to use viscosupplementation when I can. I think there's minimal risk, especially if you use the bacterial fermentation. I think the outcomes can be variable, and the onset of action in my hands is slower than those shorter long-acting cortisones. So it's more of a trend over time. Patients feel like, oh, I can't believe I was able to go up the stairs without pain, not, oh, wow, it's 3 days later and I feel like I have a new knee after my injection. So it's more gradual and we need to counsel people. But the insurance coverage is definitely a barrier. Like most of the things we're going to talk about today, this is for very early to moderate osteoarthritis. Anytime you get to moderate to severe disease or bone on bone, really none of these injections work as well. And so, I think there is still a need here. Any of the interventions that I can utilize to stay low in the totem pole as far as aggressiveness, invasiveness, and certainly if you have total joint as an endpoint, if we can throw medications, these types of injections, physical therapy, sleeves or bracing, weight management, etc., at a patient, then I think that we're doing our service. And only those who really fall out of the algorithm non-surgically need to go on to visit our joint replacement colleagues and have their replacements. And I wouldn't have patients go to those physicians until they've done and tried at least a good majority of the things we'll discuss here in this presentation. So what about Ortho Biologics? I'd like to thank my friend and colleague, Rachel Frank, for some of the content here relating to this portion of the talk. And, really this is the hottest topic in orthopedic surgery. We see the hype about quote unquote stem cells, and I'll say it once and probably 3 to 5 times here. We don't use stem cells in the United States. It is illegal. We will teach you and show you how and why. You should not be using this terminology with your patients, and we should really do our part as evidence-based clinicians to educate about what is and is not allowed here in the United States and what we are actually using as far as biologic cellular therapies to try to modulate knee and other osteoarthritis. There is danger associated with some of these types of injections, and so with great promise comes great pause, and it is on us as clinicians really to sift through and give our patients evidence-based treatments. It's, of course, also on regulatory bodies such as the FDA to ensure that we are all well within the guidelines and compliant to keep patients safe. So what is allowed? Basically, it comes down to this 361 pathway. And so these are really our autologous blood products, such as PRP that we'll discuss, our autologous cell therapy, so adipose fat and bone marrow aspirate, and to some extent, albeit more controversial as of late, amniotic fluid. And this is with the caveats and important caveats that they are not more than minimally manipulated. So that's simple mechanical preparation, so centrifuging or resizing, and only for homologous use, so the same tissue function or location. And these are critically important. And so this is what is not allowed, is culturing any cells, taking any cells out of the operating room or clinic unless it's in a regulated study, sorting cells, adding growth factors, adding enzymes to aid in any sort of harvest. And so this set of rules and regulations really helps us to determine which cells that we can target for our therapies, and really, takes away that quote unquote stem cell from the picture here, as we are not characterizing and culturing cells that are in general in the laboratory capable of full and complete self-renewal. So Ortho Biologics, by definition, are bioactive anabolic and anti-catabolic molecules that basically modulate the arthritic or regenerative process. And so you can see the different categories, and we will go through the 10,000-foot view here in a moment. But from up high, you have an injury, you have some sort of growth factors, and then you have a repair at the site of that injury. And so what are these factors? If we look closer, there are some that are good and some that are bad. You can see the good growth factors listed there on the left, things like TGF beta, BMP2, IGF-1, aggrecan. And then on the flip side, there are some growth factors that are detrimental into the joint, or cytokines that are detrimental to overall joint function and are catabolic. And these include interleukin-1, MMPs, and TNF alpha. And so conceptually, we're essentially using orthobiologic treatments and therapies to try to either provide some growth factors or manipulate the intrinsic growth factors already present within the body and within the joint, essentially to turn up the good and to turn down the bad. I think one of the key concepts in knee osteoarthritis, as Scott Dye has taught us, is really focusing on joint homeostasis, regaining balance into a joint that is out of balance. And we can use the combination of manipulating the local environment through orthobiologic and biologic injections and therapy, in combination with many of the other strategies that we talked about earlier, to affect this type of change to achieve homeostasis. So PRP, we need to understand where it comes from. So plasma is the non-cellular portion of the blood, and this is what contains the platelets and the growth factors. And so PRP, by definition, is basically a sample of blood plasma with greater than 2 times platelets above the baseline levels. The problem or the challenge is that there are multiple different systems, multiple different preparations. And so similar themes, not all cortisones are the same, not all HAs are the same, and not all PRPs are the same. And platelets have a normal biologic role for tissue healing. They also contain growth factors and proteins. And PRP essentially has this higher concentration to promote healing to the site of the injury. How does this work? It can help modulate repair and regeneration of damaged cartilage, delay degeneration of cartilage by stimulating MSC migration, proliferation and differentiation, decrease inflammation and angiogenesis of the synovial membrane. So what do? We draw peripheral blood, and the volume depends on the proprietary system. We place it into a centrifuge and spin per protocol, and then we are able to inject this either directly or under ultrasound or fluoroscopic guidance into the joint or tendon of interest. There are different systems. We need to know which we're using and why. There's a plasma-based system, which is a single spin, and a Buffy coat system, which is 2 spins. The plasma base has less platelets, but lower white blood cells, which may be important in modulating inflammation. And the Buffy coat has more platelets, but also more white cells. And so we need to be aware of white cells and understand that too much may not be a good thing, whereas in certain scenarios where things are devoid of blood supply or where we need a true healing response and not just anti-inflammatory and anti-catabolic properties, I think they may be beneficial, but that likely is specific to the body part and specific to the disease entity and specific to the type of PRP that you're using. And so really need to be thoughtful when making big, broad statements about leukocyte poor versus leukocyte rich PRP. And another theme in Ortho Biologics is that more is not necessarily better. Sometimes it is, but that's not always the case. So, I think we need to just continue to be diligent and critical as a team and as a group. But when you look at the different available PRP, again, this study in OJSM points out the variation of platelets, red cells, leukocytes, pH, glucose. And this and other papers, some of which I've been involved in, and through organizations such as the Biologic Association, are trying really to make a call for standardization and for accurate reporting in our clinical literature and our basic science literature. So, basically any variations in clinical effect of PRP might be due to just the variations in the preparations and not necessarily to the fact that PRP may or may not work. And so we need to be very cautious and careful there. But if you look at a meta-analysis for knee arthritis, you look at leukocyte poor versus leukocyte rich PRP, you can see there are several level 1 and level 2 studies, which is somewhat rare in comparison to the rest of the space with orthobiologics, where the evidence may not be as robust. And you can see that leukocyte poor PRP had improved subjective scores and functional outcomes compared to hyaluronic acid and compared to placebo. So this was in 739 patients, and you can see at 6 and 12 months, the WOMAC scores were better, and there's only one of those studies that really showed no significant improvement. This is a study looking at a meta-analysis of PRP level 4 systematic review, concluding that intra-articular PRP is a viable treatment for osteoarthritis. Again, similar themes come up, particularly for early degenerative changes, and again, shown to be more effective than other strategies, including HA or placebo treatments. Here you can see graphically the PRP up top and the hyaluronic acid down below. In the above graph, we're looking at IKDC score, and in the bottom graph, we're looking at the pain score. And you can see the PRP superior in function and pain at multiple different time points across the continuum. So at this point, our conclusion is based on the best available evidence. It seems that PRP is more effective than hyaluronic acid, and PRP, as we get it from our own bodies versus corticosteroids, especially short acting, which may boost your blood glucose and may have other systemic effects. There seems to be more safety to PRP. Certainly in our elite athletes, we are very wary of using corticosteroids for multiple reasons beyond the scope of this talk. But our athletes are much more receptive, as I believe they should be, to more natural treatment options, such as taking their own blood, isolating the platelets, their growth factors, and then targeting injection to improve their clinical situation. We tend to use leuko-reduced PRP for osteoarthritis, in contrast to leuko-rich PRP, which is used more so in some of the chronic tendinopathies. And if you want better results, treat earlier osteoarthritis. When we get to bone-on-bone arthritis, I think we're in a much more challenging space as far as utilizing costly and potentially morbid interventions for treatment. And if they fail, most conservative treatments in bone-on-bone arthritis, I think, unfortunately, they're moving towards joint replacement surgery, and you should guide them in that direction. What about cell-based therapies? Again, there's a dream, and then there's the reality. And we need to be educators. And I think this is critical. We all memorized this from our medical school days. You can see the mesenchymal stem cell and the different cell lines that these cells can go down to become bone, cartilage, muscle, etc. But, I think it's old school thinking that the MSCs are true stem cells, and that when they are introduced into people, they differentiate into regenerating tissue producing cells, and that these basically make the disease or missing tissue, curing bone-on-bone arthritis, for example. This is what our patients have thought and come in thinking, and we must dispel these notions as they are not accurate or true. And there's no one who is more qualified to tell us that we need to change the name and call people out on this than Arnie Kaplan. Really, he and others have proposed changing these MSCs to medicinal signaling cells, which is more reflective of their actual role in vivo when we put them into the body, and not stem cells. So basically, activated MSCs, and that's the terminology I will refer to for the rest of this talk, respond to the microenvironment by secreting trophic, immune modulatory, and antimicrobial factors. And so what do? They recruit our own stem cells. They secrete bioactive factors that can take on multiple roles, and they help to modulate the local joint environment. So that means potentially anti-inflammatory, immune modulatory, and all these things can effect a change within the joint that can help over time to reduce pain, improve function, and improve quality of life. And so again, we go back to this 30,000-foot view. We have an injury, we have cell-based therapy, and we have some sort of a repair. And so what is actually going on here? You can think of, the cell-based therapy not only bringing the Red Cross supply kit or airdropping it into the site of, let's say, an earthquake or a hurricane, but actually getting boots on ground to help to organize those supplies. So working closely with those people or those cells on the ground within the local environment to effect a repair and to effect healing. So the Red Cross supplies and the personnel don't stay forever. They go and do a specific job, and then the local community is supported and takes over. So I use this very simplistic analogy with my patients, and you may find it useful for yours. The ones we commonly use are bone marrow derived or adipose derived MSCs. You can see here harvest from the crest. You can also see harvest from the abdomen or other regions for obtaining fat. And bone marrow aspirate, basically we concentrate using a centrifuge. Pretty easy to harvest. You can get a high volume. There's donor site morbidity associated with the crest, and there's cost associated with all of the above. There are different proprietary kits that you can use. I have out there percutaneous and image-guided techniques to obtain distal femur, proximal tibia, intra-articular knee. There are other techniques for anterior and posterior hip. There's evidence on picking a harvest site. I think it's pretty well known that posterior outperforms anterior and outperforms distal femur and tibia, at least when it comes to the number of MSCs. but there's also ability to get MSCs in the local operative environment, in the femur and the humerus. And I think the take home here that if you want the highest amount of cells from bone marrow, posterior crest is best. But we weigh the pros and cons. There's a challenge if we're doing supine surgery to have to flip them and flip them back. And I think there's also a balance between what else is in bone marrow aspirate concentrate. Is it just the cells? They're in pretty small concentration. Is it more the growth factors or other anti-inflammatory agents that help us in the bone marrow? And so more research is needed to tease this out further. But just know that the actual number of MSCs are quite small, and it's influenced by sex, age, and harvest site. And so I think some of the growth factors listed below and others, so IRAP and others, may be doing a lot of the pushing and pulling when it comes to affecting change from the bone marrow aspirate concentrate, and we should be aware of these and not just the cells. Here's some of the evidence looking at focal cartilage defects and looking at osteoarthritis. And we can see, overall that there is reasonable evidence to support the use of BMAC for these indications. We'll get to a summary and conclusion of the use of these cell-based technologies for knee OA in my practice after we introduce the lipoaspirate. But here you can see basically taking fat from the abdomen, the flank, the thigh, or arthroscopically. We basically can mechanically process to retain that stromal vascular fraction, and that's what is rich in MSCs. There are more MSCs in fat than there are in the bone marrow. This is quite easy to harvest, although maybe less comfortable for orthopedic surgeons, but you get that large cell yield. There can be donor site morbidity, and there is increased cost compared to some of the things I presented earlier. But nonetheless, again, when you look at these microfragmented injections of fat, you can see improvement in patient-reported outcomes, some improvement in objective outcomes and second looks versus the control. And so there's a growing body of evidence for knee osteoarthritis to support consideration of adipose injections. I think the overall feeling from myself and many of my colleagues, but not all of them, is that these cell-based therapies may be useful for osteoarthritis. That's for modulating pain, function, and quality of life. Less clear whether they actually modify the disease and reduce the natural history progression towards bone-on-bone arthritis. Also, it's a wide open space as far as the dose, the frequency, the timing, the number of injections, the cost concerns, the donor site issues, and the learning curves. And so I think all those things limit its application today. Similarly, we have really good evidence about leukopoor PRP, and it's easier to obtain and easy to inject. And so it's really hard, if that's the barometer, to go to these other therapies based on the evidence we have right now. Lastly, I'll touch on Amnion. Just note that, with the FDA's continued and ramped up interest in biologic therapies, many of the companies that were commercially available have pivoted now, and rightfully so, towards studies that will lead towards a biologic license. And so they're in phased clinical trials and not available commercially. And so these things at this moment are more about potential for the future. The pros of Amnion treatments are that there's no donor site morbidity, there's point of care delivery. The cons are that it's allogeneic, expensive, and as we'll see, some have cells and some don't. So again, we have to understand what we're using, and very limited clinical outcomes. Here's a study from AJSM basically looking at 3 different commercial preparations and looking at MSCs and different growth factors, and really found that MSCs were not identified in 3 of the products, and that we're likely looking at different milieu of growth factors, hyaluronic or combinations. And so just know what you're injecting is the take-home point here, as not all Amnion is the same. Here is a multi-center study. I was involved in this, but it was led by Jack Farr from Ortho Indy and Andreas Gamal from HSS, basically looking at an amnion suspension allograft versus saline and hyaluronic acid. This was for knee osteoarthritis. This was randomized, controlled, and multi-center. Basically 200 patients, single injection of amnion versus HA or saline, looking at 6 months and now reported recently this past week, the longer term outcomes reported at AOS, but essentially lower pain scores, higher self-assessment, and higher KOOS subscales in the amnion group when compared to the HA or saline groups. And so I think this is compelling information and something that we should keep on our radar that needs continued vetting and FDA clearance before it comes back to the marketplace for use. And then even then, it will need likely help as far as insurance coverage over time so that the costs are not prohibitive for the general population. So a lot of hurdles to overcome there, but a lot of promise as well. And so in conclusion, I hope I've showed you over the last 30 to 45 minutes that non-operative interventions are effective for knee osteoarthritis. These orthobiologics are here to stay, but we must be educators to our patients. We must band together as peers and standardize the way that we talk about orthobiologics, standardize our reportings, and follow the evidence, regulate each other, and allow the FDA to have oversight and to regulate the space to keep our patients safe. I think if you're going to use steroids for appropriate indications, for me, that's acute OA exacerbations with a large effusion. I may aspirate and inject a short-acting cortisone, or consider using those longer-acting cortisones if insurance or cost issues for the PRP or others are a problem, or if patients have comorbidities such as poor blood glucose control. I think the longer-acting cortisones can be very reasonable to utilize. And so I would use those without toxic local anesthetics, and I would use the short or long-acting Kenalog for knee osteoarthritis. If you're going to use hyaluronic acid, be thoughtful about molecular weight and consider the higher molecular weight. Be thoughtful about safety and consider bacterial fermented types. And continue to advocate for patients and fight and report data, because I do think there is some value to HA, and it is being assaulted here in most of the recommendations and becoming less available to our patients and pushing patients more quickly towards joint replacement. And I'm not sure that's the pathway that we need or want to be going. Some of these interventions are humoring the patient while nature cures the disease, or at least giving them options or opportunities to get to a better place as far as load reduction, see if their pain and function are acceptable, if they modify their activities, and try not just to knee-jerk say, you have bone-on-bone arthritis, you definitely need a joint replacement. They may, but that's not a foregone conclusion. And then we saw the mounting evidence for leukocyte-reduced PRP for knee osteoarthritis, and I think that is our workhorse if it's able to be afforded by our patients. There's still a jury out whether it should be combined with HA for synergistic effects. More work needs to be done. Whether it should be 1 versus 3 injections or more, how often it should be repeated, does it modulate the joint for longer term? So a lot of unknowns, which makes it an exciting space. And watch the data for BMAC and Amnion and for adipose. As I think if there's more compelling information, particularly comparative and longer term and disease modulating and X-ray modulating versus PRP or others, that it may come further into the fold. And I thank you so much for your attention, and I'm happy to take any questions at this point.
Hi, everybody. I'm Seth Sherman, and I hope that you enjoyed my overview and presentation on these novel treatments, non-surgical for knee osteoarthritis. We'll be here for the next 10 to 15 minutes taking questions in the live chat. Fortunately, I see that there's a good amount of excitement around this topic, and that we have many questions coming in already. And so I will just kind of start going through them from top to bottom. The first question that I see here is, there still a role in your practice for cortisone and hyaluronic acid in the management of knee osteoarthritis? I alluded to that in my talk. The short answer is yes. We try to treat these patients in a stepwise manner. And certainly, short and long-acting cortisone both do still have a role in my algorithm. I tend to use short-acting cortisones when patients have a real arthritic flare. If they have known arthritis, they tweak their knee, they have large swelling, pain, I can aspirate and do a short-acting Kenalog, and in that scenario, I can often quiet the joint down quite readily. Similarly, I might use longer-acting cortisone when I'm going for a longer-term strategy. These can last and stay in the joint 4 months or longer. Usually use them in quieter knees, sometimes post-surgical knees that we know have known early to moderate osteoarthritis. So I think that there's a good role there for that, and in diabetics, because there's more stable glucose control with the longer-acting extended release products. For HAs, insurance has become a barrier a lot based on following suit with some of the national and international organization recommendations. For better or worse, that's kind of where we are. We don't always get to choose or have the option to do HAs, but nonetheless, we try to use them in the mid part of the algorithm before I'll consider many Ortho Biologics if they're covered by insurance, for sure. And usually, again, in those more chronic scenarios, patients with known OA, people who might want to avoid joint replacement for years, and we're trying to get them on a regimen of maybe injections every 4 to 6 months if they have continued efficacy. Again, for those, we're trying to use either single or 3 injection series. We're doing high molecular weight. We're doing typically bacterial fermentation products, although we don't get to choose as much, as we used to. But hopefully that gives an overview of that question. The second question, in addition to injection therapy, what other interventions do you find successful in the management of knee osteoarthritis? I think if you take anything from my talk, it's that we're really taking a comprehensive and multi-pronged approach to treating knee osteoarthritis. It's not, unfortunately for the patient, quick and easy injection and then forget about it. It's a lifelong problem that needs to be managed. And the ways that we really can get the best bang for our buck from any injection, including Ortho Biologics, will be to make sure that the patients know that rehabilitation, either physical therapy or home exercise program, have to be part of their long-term strategy. We make sure that they undergo some sort of load reduction. So that's weight loss through nutrition and or low impact activities, combined with either assist device for a short term, that's a cane, crutches, walker, whatever, and or bracing, unloader bracing, etc. If people are neutral aligned and just for swelling, proprioception, maybe to reduce inflammation, I use knee sleeves as well. And then medical treatments, we institute anti-inflammatories, especially if we're not doing PRP or other orthobiologics. We'll do that early. If we're doing the PRPs, then we tend to have a washout period of anti-inflammatories and then introduce them later after the injections have taken hold. We use Tylenol as well. And that's pretty much my grab bag of things that I do for the majority of patients with OA non-surgically. We'll go to another question. What was your mixture of corticosteroids to avoid chondrotoxicity? I really love that question. We have several in vivo and in vitro studies to kind of back this up, and colleagues at my own institution, Connie Chu, and friends and colleagues around the country have also looked at this. But in general, I would ditch the local anesthetic. There's really not a huge role in my hands for putting 1% lidocaine into the joint. I think if you're going to do local anesthetics, consider very dilute bupivacaine or consider ropivacaine alongside your treatment. But I find just prepping the knee, doing a cold spray on the surface, and then using a saline vehicle. I usually use 3 cc's of saline along with my cortisone. It gets the job done. And so we've also learned that not every cortisone is the same. And so I have found with our team that Kenalog seems to be the safest for chondrotoxicity and for synoviocyte toxicity. Interestingly, it was also similar in our models for tendon toxicity in rotator cuff models. So we use Kenalog 40 milligrams as our short-acting cortisone of choice in a saline vehicle. We'll go to the next question. Can you inject PRP without utilizing ultrasound guidance? The short of it is that you can, but we question whether it's localizing or as accurate. In general, PRP is not insurance covered. It is more expensive and usually out of pocket. And so it's not unreasonable to consider localizing it with an ultrasound. I think the times where ultrasound should most certainly be utilized if you're localizing in and around tendons or specific structures within the joint or around the joint. Certainly for shoulder AC joints or small joints, it makes great sense, or the shoulder joint in general. I think knee surgeons get into the knee often, and so we may argue that we can know that we're in and we can administer this without ultrasound guidance in the clinic. That said, I refer to my non-surgical colleagues for many of these just because of the time and labor and effort associated with harvest, spin, and then I think it's prudent in those scenarios because of the high cost and to ensure accuracy, showing your needle in the joint on ultrasound and getting the job done that way. So I'd encourage you probably, if you're going to be doing this in mass, to do the majority ultrasound guided, and then but I think there are exceptions where you don't necessarily have to. I think the discussion about cost is a challenge. It's different at every institution, and the majority, I think there's bundles and different plans, and really difficult. I think the price varies so widely from a private clinic down the block to what we offer at our institution that it's really hard for me to wrap my head around having to give you pearls in a few minutes about truly cost. But I would say that the best scenario would obviously be using the evidence to get insurance approval, and that would help us. And I hope that's coming soon because there is growing evidence. I think that cost should be considerate of the amount it takes to prepare. So the kit, and then the fee for injection, which should be commensurate to other non-ultrasound or ultrasound guided injections. And then I would say, just because this term bothers me, stem cell. We don't offer quote unquote stem cell injections here in America. They're not legal. The things that we do are on occasion signaling cells that come from the bone marrow or the fat that are minimally manipulated. And so anyone who says they're doing stem cells or advertises stem cells, I think that can be a bit misleading, and I would be careful there. These cells don't go into the body and turn into cartilage and regrow a bone-on-bone joint. They may work in a paracrine fashion with the cells on the ground to reduce catabolism, to reduce inflammation, to help the cells that are on the fringe to feel healthy enough to restore, matrix, amongst many other properties. But please get in the habit of not using stem cell when you're talking about what we are able to offer our patients here and now in 2021 in America. We'll go down to a few more questions. Is there a role for prophylactic PRP in athletes with suspected early onset osteoarthritis due to injuries such as ACL or Triad injuries in the knee. I think this gets to the core of what these orthobiologic injections can do and what they cannot do. As we said, these injections are not to regrow anything in the joint necessarily. They are to help bring about knee joint homeostasis. And so we don't, in short, do prophylactic injections for anyone, elite athletes or otherwise. If you have a joint that you know has early osteoarthritis, the joint has swelling, it's inflamed, it's lost some motion, they're having challenge with their rehab, either non-surgical or post-surgical, that's really where there's a role for these injections, and that would not typically be prophylactic. And so patients are always concerned about the future, and that's okay. But the majority of our treatments are towards intervening for symptoms in the here and now. And hopefully that will get balance enough to carry into the future so that there's less breakdown. If their joint is on a steep slope downwards towards symptomatic osteoarthritis over the long term, then maybe we can level that playing field out graphically. And then if they maintain their envelope of function so they don't exceed a level by which it irritates the joint, then we can improve their pain, reduce their functional issues and disability, and improve quality of life. We'll keep going here for another 3 minutes or so. I don't understand the donor site morbidity question, so I will skip that one for now. Any recommendations for systems to harvest leukocyte-poor PRP? There are several proprietary systems out there. Obviously, it will matter about your hospital, negotiating power, vetting several different systems, seeing what fits with your flow, whether you're doing this in the clinic, in the operating room, or both. And so I think many of the systems just really don't want to get into proprietary names here, but many will offer the opportunity to do leukocyte-poor versus leukocyte-rich PRP. They'll give the opportunity for you to look at the platelet counts, to look at the concentrations and amounts of white cells. There are other more expensive systems that you can use to independently verify what your cell counts are. I think as we do clinical studies and multi-center studies, many of the big institutions have these. So we have a secondary check, not just from the proprietary company, but also independently what we're actually injecting into patients. So we can build sort of a biorepository and learn whether we're injecting what we think we are and whether it's doing the job we think it's doing. But I do think it's important to have a strategy based on best available evidence for leukocyte-poor or leukocyte-rich. The last question about Patellar Tendonitis is a good segue into that discussion because in general, if you have chronic tendinopathies where we want to go for a healing response, then it may be reasonable to consider leukocyte-rich, platelet-rich plasma. That means more of the white cells. That way we may get more inflammation at the site, stirring up a cascade that may lead towards healing, which is very different than what we're doing in synovitis, intra-articular inflammation, osteoarthritis, where these joints are inflamed, irritated, catabolic, and we're trying to get homeostasis by reducing inflammation and calming down the joint, basically using orthobiologics to turn up the good growth factors and cytokines and reduce the bad ones intra-articular. And so that would be more for leukocyte-poor platelet-rich plasma. I think we know, unfortunately, that ACL surgery, even when well done, while it can improve function, get people back to sport in most cases, it does not necessarily reduce the risk of osteoarthritis. And so those patients are often good targets a decade later if they have symptomatic early OA to consider PRP injections. This would be in general leukocyte poor, platelet-rich plasma. I'm not currently using PRP for partial ACL tears to try to get them to heal in the acute or subacute settings non-operatively. I think there's some emerging information on that. And I'm also not using PRP intra-articular or wrapped into the graft or other orthobiologics wrapped into the ACL graft to improve aperture healing or ligamentization, although Adamans and others are writing on the use of some biologic agents for those purposes. So in summary, this is a hot topic. There's a lot to learn. My talk will be different next year than this year, which makes it exciting. We keep our pulse on the literature. We really want to do no harm and not break the patient's bank and really focus on your education around quote unquote stem cells and help us to rein in any of the rogue clinics that are outside of our thought process and bell curve so that we may treat our patients effectively, efficiently, and cost effectively. And thank you very much.